So, good afternoon, everyone. My name is Olivia Gray, and I'm a Sexual and Reproductive Health and Wellbeing Project Officer for the Centre of Excellence in Rural Sexual Health. And I would like to welcome you all to the Addressing Rising Rates of Congenital Syphilis webinar, which is part of SERSH's Sexual Wellness Professional Development Series, and today will be presented by Dr. Stephanie Bond, who I will introduce shortly. But before we begin, I would like to acknowledge the traditional owners of the lands and waterways across Australia from which we are all joining this afternoon. I pay my respects to elders past, present and emerging, and I extend that respect to all Aboriginal and Torres Strait Islander peoples with us today. I also acknowledge the deep importance of Indigenous knowledge in the field of sexual and reproductive health. Housekeeping notes for today's session. We kindly ask that everybody remain on mute during the presentation. Please feel free to share your questions into the chat and I will go through questions at the end of the presentation. This session is also being recorded and will be available on the SERSH website next week should you wish to revisit or share it with your colleagues. So let's get to know our speaker for today. I would like to introduce Dr. Stephanie Bond. Dr. Stephanie Bond is an obstetrician and gynaecologist, as well as a sexual health physician at Melbourne Sexual Health Centre, the Women's and Mercy Hospital for Women. She is the Vice President of ANZVS and clinical lead for sexual health at the Royal Women's Hospital. She is also currently undertaking PhD research into congenital syphilis prevention. Thank you, Dr. Bond, for presenting this afternoon, and over to you.
Thanks so much for the opportunity to present today. I'm really pleased that everyone's logged in online, and don't forget that this session will be recorded. So please feel free to send it out to your colleagues. So I'm coming to you from Wurundjeri land, from the people of the Kulin Nation and their unceded land where I live and work. And I'd like to honour elders past and present and any Indigenous people that are online today. So on the slide here, we've really got the new and the old. So we've got an electron microscopy image of the Treponema pallidum here in the middle. And on the left-hand side, we've actually got the oldest representation of congenital syphilis. And the thing I find a little bit depressing about this is that still today, we're still talking about managing congenital syphilis. This is something that should be highly preventable, is 100% treatable with benzathine penicillin, and yet more than 600 years later, we're still dealing with this ongoing issue. So you can see here, this is actually a jug which dates back to the 7th century, which depicts a mother suffering from syphilis holding a child. And the mother has got this syphilis, the saddle nose and these superior incisive teeth with notches, which happens with syphilis that is contracted in utero. And then on the right here, we've got a picture. It's actually a woodcut by Albrecht Dürer in Germany from 1496, which is, this is a mercenary here with these skin sores, which are these multiple chancres or probably late stage or tertiary syphilis. So whilst we're talking about syphilis today in 2026, this has been an issue for many hundreds of years. And I really hope that within the next decade, we start to make some progress in terms of syphilis control. I also just wanted to say that sometimes I find that I'm giving this talk to a room or a virtual online room of people who already know a lot about syphilis. So this is a talk that can be given in your general practice setting. It can be given in your clinic setting. It can be given in your rural setting. So please contact me if you'd like any of my slides. I'm more than happy to share them, because really this is about trying to find some local champions. You guys are going to know all about syphilis by the time I finish talking. And I guess I'm here to give you the message, okay, we know about syphilis and the importance of testing and how to treat syphilis. So we really need to let our colleagues know, because there's many, many clinicians out there who have lots of competing concerns, lots of other things to think about. So I'm really, I guess, starting with a plea to you to say, whilst I'm giving you the information today, I am more than happy to share it. And I'm really hoping that this is an opportunity to spread the message far and wide. So you may have seen the most recent ASHM public health messaging about syphilis being back. Syphilis needs to be back on your radar. And so that's why this is a really great opportunity to talk today. I have no disclosures to make, but at the end, I will be providing my contact details and also saying thank you to my colleagues who've really contributed to my work and interest in this area. So just a little bit of interaction for those that are logging on online. There's a QR code here. Please feel free to scan it with your phone or whatever you have nearby. This is a poll, and I just want you to think, okay, so if we're thinking about congenital syphilis, these are babies that are infected with syphilis in utero and then not treated adequately or not followed up. What might be the biggest barrier that you can think of to prevent these cases from occurring? And you can just pop a little, if you vote in the poll, then you'll see the results of everyone else's votes as well. And then hopefully we'll be able to have a bit of a reflection on this at the end of the talk. And I guess sometimes it's worth thinking about in your clinical setting, if you came across syphilis, would you know how to test for it, how to treat it, or where someone should go to be able to access those resources? I'm going to talk a little bit about Victoria, and obviously I'm sitting here in metropolitan Melbourne, but I would acknowledge that there are outbreaks of syphilis in different parts of Victoria and across Australia. Earlier in the early 2000s, there has been, or early 2010s, there's been an outbreak in the Mildura area, which has been actively managed through the public health units in that area and really active work by clinical staff working in that setting. But we're now seeing syphilis in many, many different settings. So what you can see here is that Victoria has seen a steady increase in infectious syphilis notifications over the last decade. And some of our more senior colleagues may have trained in the early 2000s when really there was not much syphilis around. So clinically, things have really changed. And I think that's why education of all clinicians is going to be so important. The highest number of notifications were recorded in 2023, and the number of notifications probably underestimate the burden in the community because a high percentage of people who were tested actually were unaware that they had it. So they had asymptomatic infectious syphilis. Concerningly, congenital syphilis has re-emerged, and these are these red boxes at the bottom here. You can see that there's been 21 cases notified since 2017, including 11 deaths. So this is a catastrophic outcome, and this really shouldn't be happening in the Victorian setting. We have seen similar trends reported nationally, and I will show you some national data in a moment, but there's been a record high of 6,500 infectious syphilis cases and 20 congenital syphilis cases reported across Australia in 2023. So I'd like to introduce you to my patient. So this is SM. She's a 38-year-old woman who's living in Western metropolitan Melbourne. She's 38 years old. She's had 3 previous children, and she has lots of complexity in her life. Her housing is unstable. She has some mental health concerns, and she has experienced recent family violence. She's had 3 previous caesarean sections in 2010, 2012, and 2016. Those children aren't in her care. She presented to a GP practice. This is the first time she'd visited that particular provider and that particular clinic. And she said that she'd had a sexual partner with syphilis and someone had told her that she needed to be tested. So dutifully, syphilis serology was ordered and she did go and have her blood test done. She did complain of a rash, but there weren't many other details provided. And a week later, sure enough, her syphilis blood test came back, showing that her syphilis antibody was reactive. Her RPR was 256. But the problem was that this patient was nowhere to be found. We'd taken a blood test, but we were unable to contact her after that. So I just want you to stop here and think, okay, well, how could we have prevented this? Or at what point could we have done something in our system that could have changed the outcome? Because what we really need to think is in our clinical practice, what sort of safeguards are we building into our care? So what I've discovered from looking at and looking after a lot of people who are diagnosed with syphilis in pregnancy, it's not because people don't want to access care. It's because of barriers in the system and things we need to do better as health professionals and other allied health staff to make sure that care is provided adequately. And I guess I would sort of argue that this patient had a rash. Should they have been treated as a contact with syphilis at that time? And that's easy for me to say as a sexual health physician sitting in a tertiary sexual health service in metropolitan Melbourne, where we're seeing lots of syphilis every day. But it's not so easy for the average primary care practitioner who's out there in the community, who sees on average per year 0 syphilis cases and has a whole list of other patients waiting in the waiting room. So we really need to get awareness out there so that people know what resources do we have so we can manage these patients appropriately. Syphilis is preventable. So this is not just an Australian problem. Globally, cases are rising. And because we know that we can give penicillin to treat syphilis, what we really need to be doing is making sure that we're testing and able to access our most vulnerable populations. I've talked about the severe outcomes. So in Victoria, we have seen plenty of cases of stillbirth, neonatal death, but we've also got to think about long-term morbidity and mortality that can come from congenital syphilis. And the other thing about syphilis is, especially syphilis in pregnancy, is that it is a marker of other health system gaps. So really, whilst I'm here talking about syphilis, we have to think about the broader picture. Where are we providing care in our drug and alcohol services? Where are we providing care in our prisons? And think about how we can address some of the gaps in care that we have both locally and, we're seeing this on a global level. So this map here shows the cases of congenital syphilis per 100,000 births, and you can see that in some parts of the world, rates are catastrophically high. So we also need to think about where our patient population is coming from, and some of us may even be going to work in some of these very high prevalence areas. This is a graph which shows global syphilis incidence over time. So really what I'm saying to you is that this is an emerging issue and it was not such a problem 10 years ago. So we really need to change our thinking and the way that we are approaching this problem. The red dashed line here represents the age standardised incidence rate per 100,000 population, and you can see that it continues to rise. And really, I see no reason why our interventions so far will have made any impact on this, to be totally honest with you. So we need to start thinking very, very broadly as to how we can address this problem, both locally and on a global scale. So this is a key issue that has been highlighted by the WHO, who estimate that 700,000 congenital syphilis cases and 390,000 adverse birth outcomes are annually caused by syphilis. And these numbers are just enormous. It feels almost pointless to call them out. But if you think about it, these are individual pregnancies that are affected by this by syphilis. And I guess the real tragedy in this is that if we could have tested or reached this population and then treated them, then we could have prevented these problems. We know that penicillin is safe, relatively inexpensive, and should be accessible. So these are things that we need to address on a global scale. There's also a disproportionate burden in low resource settings. And you can see here rates in the African region, Eastern and Southern Africa, are incredibly high. So these are the cases per 100,000 live births. But we're also seeing increasing cases in high-income countries. We've seen the situation in Victoria, and this is where it becomes a marker for the quality of antenatal care as well. So we're not just providing testing, we also need to allow people to be able to access antenatal care. So the WHO has a framework for triple elimination of mother-to-child transmission of HIV, syphilis and hepatitis B virus. And basically what they're aiming for is the congenital syphilis case rate being less than 50 per 100,000 live births, greater than 95% antenatal clinic coverage. So this is at least one visit in antenatal clinic. greater than 95% coverage of syphilis testing for pregnant women, and greater than 95% adequate treatment. And I guess I'm here to say, to show you that unfortunately, in some areas of Australia, we are not meeting these progress indicators. And I'll show you some of the Australian data in a moment. In the US, they're calling this a public health emergency, and there's lots of really fantastic data out of the US showing the impact of testing and treatment and the gaps in the syphilis care cascade. So this study on the right-hand side is looking at the syphilis care cascade, and it's looking at different missed opportunities for preventing syphilis. So things like missed maternal screening, delayed treatment, fragmented care. The CDC has recommended universal early screening, so this is in the first trimester, and then repeating at the third trimester and at delivery in high prevalence areas. But this is a dramatic problem in the US. In the UK, we have very, very rich data about the syphilis care cascade, and I would draw you to the ISOS syphilis report. There's really amazing information about how we follow up mothers and their babies in the UK, which is available widely online. And there is a high uptake in the UK of universal booking visit screening. And there's been really strong surveillance over the years. But when they're looking at cases, late booking or not receiving any antenatal care remain significant contributing factors to transmission. And in a small number of cases, there's also been issues with clinical management. And I would say this could be generalised to the Australian setting. This graph here shows the cases of infants with confirmed congenital syphilis from 2015 to 2024. You can see that there's definitely rising rates and still plenty of diagnoses post-birth. So there's lots of opportunities for these cases of syphilis to have been picked up that have obviously been missed along the way. On the right-hand side here, and this is something that I would be quite interested in implementing nationally in Australia, is the UK Syphilis Birth Plan. So this is a mandatory document that's added to a care plan for every person who's diagnosed with syphilis in pregnancy, with details of their syphilis diagnosis. And the uptake of the use of this birth plan has been very, very high across the board in the NHS, and is something that we could consider. Obviously, it is a paper-based system and a lot of services are moving online, and I'll be talking about the benefits of that. But the really useful thing about this is as a communication tool between clinicians. So whilst we might make our diagnosis in whatever setting you're in, whether that's in an Aboriginal community controlled clinic, in a primary care setting, in an emergency department, but then how are we then communicating with other antenatal care providers, with our midwifery care teams, our obstetric colleagues, and importantly with our neonatal colleagues to ensure that that person has adequate follow-up. So it's not just about finding the syphilis, treating it adequately, but also making sure that the communication happens so we can manage neonates effectively. Often these are incredibly complex patients. People have lots of other vulnerabilities and issues with access to services. So sometimes something like this can be really helpful, and this is widely used in the UK. I'd now just also like to turn to our closest neighbours. So if we look in the Pacific Island countries, you can see here that our Pacific neighbours are also disproportionately affected by syphilis, especially in pregnant women. We don't have amazing data, but the available data does suggest that Pacific Island countries have among the highest global prevalence of syphilis. So if we think about some of our schemes, including our PALM worker schemes, where we have transit of working populations of women of reproductive age and men from these areas, we can see that we may be actually importing a lot of cases of syphilis, and this is an issue definitely that needs addressing because we're ending up with lots of syphilis right on our doorstep. So syphilis positivity data among pregnant women attending antenatal care was available for 14 Pacific Island countries, and it ranged from 0% in the Cook Islands to 10% in Tuvalu. But I don't think this data is sufficient, to be honest, and it doesn't report on all the indicators. We know that there's definitely low levels of testing among pregnant women, and this has obvious consequences for ongoing mother-to-child transmission. And also, many of these areas are starting to use point of care testing, which I'll be talking about a little bit later on. And perhaps expanded use of point of care tests could strengthen testing, particularly in areas where we don't have easy access to laboratories and other resources. So I think we need to think outside the box. And we also need to be aware that we are having transit of populations from our closest neighbours, and we may find them within our communities. So we just need to be aware of our local epidemiology. And finally, we're getting to Australia. And I think this is on the left-hand side is data from Belinda Hengel and her colleagues, which shows notification rates for women aged 15 to 44 years in Australia. And what I just really want to point out is that actually the x-axis, so if you look, the top graph is Aboriginal and Torres Strait Islander women and the bottom is non-Indigenous women. And actually we're looking at a completely different scale. So Aboriginal and Torres Strait Islander women is on a scale far higher than Indigenous women, and this demonstrates the enormous burden of syphilis in Aboriginal and Torres Strait Islander people. So between 2020 and 2024, infectious syphilis diagnosis rates among Aboriginal and Torres Strait Islander people remained at least 5 times as high as among non-Indigenous people. So we really need to think about community-led responses to this important issue. So we're seeing reports of congenital syphilis in multiple jurisdictions, and these should be treated really as sentinel cases. We should be reviewing these, and we are doing that in Victoria, looking at why have they missed screening? What's happened to treatment? Was there inadequate follow-up? On the right-hand side is data from the Kirby and the annual surveillance report from 2025, which shows the same story, just an incredible increase in infectious syphilis notifications in women of reproductive age. So whilst I'm talking about targeting pregnant women, in order to actually address this problem, we need to be thinking about all women of reproductive age, and we also need to be thinking about men who are then perhaps causing onward transmission of the infection. So partner notification is going to be of great importance. But I would just also note the importance of safe partner notification. So if we think about some of the risk factors for syphilis in women of reproductive age, or common epidemiological factors, we do often see that things like family violence, housing instability are incredibly common. So it may not be safe for individual women to be notifying sexual partners about syphilis infections, which might put them at increased risk in the future of reinfection. So this is definitely a complex area. It's no easy fix. But these are just some of the issues that I have been grappling with as part of my PhD. This is data from the Department of Health and Aged Care, and really this shows congenital syphilis rates since 2016. But I guess, want to draw you to the red boxes, which are babies that have died. So the sequelae can be absolutely catastrophic. And I'd also highlight the cases of congenital syphilis, again, in Aboriginal and Torres Strait Islander people, which emphasises the need for culturally safe care and also community-led implementation of some of the things that I'm going to be talking about. We're nearly at the end of the epidemiology, but I just think it's important because you're coming to this talk from all around, and you might have ability to talk to your colleagues in other areas. So it can be really important to think about what's happening in your local area, but also on a more global scale. So in New Zealand, we have seen a similar story. So the number of infectious syphilis notifications has increased in 2022 and 2023. There were 32 cases of infectious syphilis among pregnant women, and the cases of congenital syphilis have fluctuated between about 2 and 8 per year. But unfortunately, the New Zealand data is likely to be a significant underestimate of the true burden because notification really relies on clinicians. Also, pregnancy loss is not always investigated, and therefore there might be additional stillbirths which are attributable to syphilis which haven't been reported. So that's something that we can also think about in the Australian setting. So let's just get back to the basics about syphilis infection. So maternal to fetal transmission of syphilis infection can occur in utero in any trimester. And this happens via transplacental transmission or much less commonly during delivery via direct contact with an infected lesion. The highest rates of transplacental transmission are observed in untreated mothers with early syphilis, so primary or secondary syphilis, in the third trimester of pregnancy, and 60 to 100% of those babies would be infected. Compared to mothers who have early latent or late latent syphilis, however, despite all this, we do actually know that if we detect and treat syphilis more than 4 weeks prior to delivery, then this results in an almost 100% chance of preventing infection in the infant. And actually, when we look on ultrasound, we see some of these early signs of syphilis infection of the fetus in utero. They can actually reverse with time after treatment. And that's why ultrasound surveillance of babies that have been infected with syphilis in utero is so important. So we've had cases of anemia and change in MCA Dopplers on ultrasound, which have required early delivery. And that's why picking up syphilis early in pregnancy is one of the sort of key parts of preventing transmission, maternal to child transmission. Treponema pallidum is not known to be secreted in breast milk, and this is a really common question I get asked. The patient has been breastfeeding. What should I tell them? They've had new diagnosis of syphilis, but there is a small probability of transmission of syphilis from direct contact with a sore or a skin lesion. So, for example, if there's a lesion on the nipple, the breast tissue during breastfeeding or breast milk expression. Breastfeeding is certainly not contraindicated in perinatal syphilis, and it's certainly considered safe in the absence of any lesions on the breast. So it has no impact in that setting. So excitingly, the Australian Pregnancy Care Guidelines did change last year to talk about syphilis testing in pregnancy, and I'm sure a lot of you are aware of this. But this has actually given us a great opportunity to start to talk about syphilis with our colleagues, a foot in the door, I guess. So, for example, with our antenatal care providers, because of this change in the Australian Pregnancy Care Guidelines, we can now talk about we're doing a fantastic job of this green box up here, universally offering and recommending syphilis at the first antenatal contact. And that is very, very well entrenched within antenatal care in Australia. And that's great because it meets the WHO goal of allowing for testing in early pregnancy. But then what happens if someone goes out and has sex again? And, you know, as we know, that absolutely happens. There's always a risk of reinfection as the pregnancy goes on. And this reinfection is of great significance because if you're infected with early syphilis later in pregnancy, the fetus is at even higher risk of developing congenital syphilis. So the guidelines have now added a recommendation to universally offer and recommend additional screening at 26 to 28 weeks and at 36 weeks or birth. The good thing at about 26 to 28 weeks is it is a time when pregnant people are having repeat blood tests. So this is normally when diabetes screening occurs, also a repeat FBE to look for anemia, sometimes other testing. So it's not requiring an extra pathology visit. We should be able to just incorporate it into our current clinical workflows. And then the same with testing at 36 weeks or birth, whichever's earlier, regardless of assessed risk. So when we think about risk, and I think when we look at cases of congenital syphilis in Victoria and syphilis in pregnancy, we do know that there are some risk factors for acquiring syphilis. However, we do know that there's also a number of pregnant people who have none of those risk factors. So we've moved away from recommending risk-based testing. Also, it's really difficult in the antenatal care setting to do a good risk assessment. There's so many competing priorities. Sometimes there's the partner in the pregnancy sitting there in the room, and sometimes there can be significant stigma or other things happening, which means that risk is not accurately disclosed. Also, by testing at regular points during the pregnancy, this normalises syphilis testing for both clinical providers and also for patients. So this can address stigma and shame and other concerns. And so when we routinely screen, this allows for this normalisation of testing. And we've done similar things in the HIV space in terms of removing the requirements for designated consent for HIV testing to really normalise testing commonly for people accessing healthcare. And I will just mention that for those who are assessed as being at increased risk of syphilis, and this might be because of where they're living or other epidemiological reasons, the current Australian pregnancy care guidelines are recommending testing at 5 points in time during pregnancy. And for those that have worked outside of Victoria, this is very, very well entrenched, for example, in WA, Northern Territory, Queensland, where testing has been done like this for a very long time, and these outbreak conditions have been present for a lot longer than in Victoria. So if we think about our steps to prevention, we've talked about early antenatal screening, and that's all well and good. And I guess I've got this list here of what we need to do to address congenital syphilis, but I'm here to acknowledge the complexity behind this. So if we screen people early and we detect syphilis, then we can treat them adequately. But the problem is that a lot of people are unable to access antenatal care, and there can be so many different barriers to that. We also want to offer repeat screening later in pregnancy, as I've just talked about, the new recommendations in the Australian pregnancy guidelines. But then we need to offer timely maternal treatment. So do we know what penicillin we're giving? What resources are we going to access? How are we going to access penicillin, benzathine penicillin? And I'll talk a little bit about the shortages that have been experienced in Australia in a little bit. Partners. So if we've done half the job, which is treat the person before us, if we don't treat their sex partner and they go home and are reinfected with syphilis later in pregnancy, they're actually at higher risk of sequelae for the infant. We need to be thinking about some of these competing priorities, and this can be super complex. And I'm here to tell you that there are lots of supports around, including through the Department of Health, to help you with adequate partner management and follow-up. And then infant follow-up is incredibly important too. So once that baby's born, we need to have adequate communication with our neonatal teams, follow-up of the infant going forward. And you may see this infant in your primary care setting, in another setting, maternal child health setting, and they may not have already been tested for syphilis. So we have really nice care guidelines in Victoria that these babies should be followed up, for example, through the Royal Children's Hospital Infectious Diseases Service. But we all know that sometimes there can be many, many barriers to this. Accessing the service, living in different parts of Victoria, transport, the cost of attending for screening, all these things can have a role to play. And I'm going to be talking about them in a little bit more detail. So I would just also point you towards some really fantastic guidelines that are available online. On the left-hand side is the Queensland Clinical Guideline, and I guess my hope is in Victoria that we'll get our own version of this. I do have it as part of my syphilis project in some of the sites that in Victoria where we've implemented a specific guideline in each site so that hospital settings know how to manage syphilis in pregnancy. But the Queensland clinical guidelines are a great resource and you can definitely access them. At the top there is the Melbourne Sexual Health Centre Syphilis in Pregnancy Treatment Guidelines, which also have some useful information. And the Melbourne Sexual Health Centre clinician phone line where you can chat to a sexual health physician and get advice is also available. Down the bottom here is some resources through the TGA, which talk a little bit about the treatment options with penicillin that are available at the moment. I talked a little bit about shortages in supply, and I'll tell you a little bit about that in a moment. So basically what's happened is that the Biosilin long-acting 1.2 million unit syringe, which is absolutely our preferred option for syphilis treatment in pregnancy, has had its supply limited by Pfizer. And so its use in Australia has been limited to emergency supply only. But there are plenty of other products that contain benzathine benzyl penicillin, and these should be prioritised for use in some conditions. So we're definitely using it for syphilis in proven or suspected cases, or if someone's identified as a sexual contact of syphilis. Obviously, there are other settings where we're using benzathine penicillin, including treatment and secondary prophylaxis of acute rheumatic fever, secondary prophylaxis of rheumatic heart disease, patients who require treatment for group A strep infection, who are at high risk of acute rheumatic fever. So there's lots of really priority groups who need access to this medication. So where patients fall outside this setting, we should be using alternative antibiotic agents so we can preserve our supply of benzathine penicillin. So to help cover these supply gaps, the TGA has approved the supply of other overseas registered regimens, and that was the little table that I had on the previous slide. So here in the purple. At the moment in the doctor's bag, we have the product from Portugal available, the lenticillin here in the blue with the blue top on it. And obviously the reconstitution of these differs from product to product. So I would just point you to the TGA guidelines so that you can access them as needed. But obviously this is a big issue. The last thing we want if we're addressing congenital syphilis is to have confusion in the ranks, and we need to make this as easy as possible for clinicians. So that's why I just wanted to point you to these really useful resources. So we're going to get back to SM, our patient. So we had many attempts to contact her by phone, email. These were unfortunately unsuccessful. We definitely referred her through to the Department of Health for notification, and she was eventually seen in a tertiary sexual health service in July last year. At that time, she wasn't pregnant, her rash had resolved. She had the same ongoing regular sexual partner. She had no contraception on board. Her syphilis serology, her RPR was 128. She was untreated, as you remember. And completion sexual health screening was also completed. And I would just flag to you that if we're diagnosing one STI, we should be testing for the other STIs. So, for example, a chlamydia diagnosis, a PID diagnosis, please make sure that people have bloods or serology for HIV and syphilis. Anyway, she was treated with IM benzathine penicillin at adequate intervals in July last year. But in October, she saw a new GP, a new practice, and she was pregnant at this time, about 8 weeks pregnant with an RPR of 128, and she described a vulval ulcer. So I've taken this from the MSHC STI Atlas, which I'm sure many of you are familiar with, but there's some fantastic images of syphilis on there. What are the possibilities here? Just have a think. Probably a new infection. Was it a reinfection from the same untreated sexual partner? Or was it a no falling titer? I think that's less likely. We're worried about this, right? We want to treat it, but no treatment was given on the day of the review. So we've got to stop and think again, at what point could we have done something in our system to have changed the outcome? So we've got to think about gaps in care. This is not SM's fault that she's had syphilis reinfected. She's sitting in a part of Melbourne where there's high levels of syphilis. She's been reinfected by an ongoing sexual partner, and she's now pregnant. So this study here looked at gaps in care. So we think about during pregnancy, did they enter into antenatal care? Was there some other social or economic factor which meant that they couldn't enter into care? Did they have their first trimester screening? If they had a positive test, were they treated adequately, or was there a gap in care? Was their partner treated? And then did they have repeat testing in the third trimester as per the guidelines? And I guess what we're seeing here is that there's often inconsistent repeat screening and also issues with delayed or missed treatment. We need to give the right treatment at the right time. Also, we need to think about rural and remote access to healthcare, stigma. We also need to probably have a no wrong door approach. So if this person comes to you in the emergency department, they probably need to be tested, and we need to have really good protocols for following up of results. And in the UK, opt-out testing is something that is being explored much more widely, and I think something that we could think about here in Victoria. Contact tracing is obviously of incredible importance, letting partners know, making sure that partners are followed up adequately. So back to Miss M, she's now SM, she's now 10 weeks pregnant and she has active syphilis. There's definitely a risk of transmission to the fetus. She was eventually presenting to the local emergency department for treatment with iron benzathine penicillin. But unfortunately, she had a very, very long wait. There was some discussion with the infectious diseases team, a long time for the medication to be supplied from pharmacy, and a long time for administration. The regular partner wasn't there at that time, and we couldn't treat them. The patient went on to have minimal antenatal care. They presented at 36 weeks to their local hospital with contractions, and their syphilis serology was repeated. Luckily, the patient mentioned that they had had syphilis diagnosed earlier in pregnancy, so those tests were run. The RPR had fallen to an RPR of 8, and the person was asymptomatic for syphilis. So we just need to think again, where else could we have intervened here? And really, this has nothing to do with encouraging SM to access care. We need to have accessible care in lots of different settings. We need to have culturally safe care in the antenatal care, antenatal sphere. And then we need to really have good access for partners to also be treated, and probably education for clinicians so that there's not a 6-hour wait for review in the emergency department, which might be one of the reasons the partner didn't present for treatment after that. So we can think about where the system failed: repeat screening, rapid treatment, community-led care, thinking about a few of those things. And you can all think about that in your own individual setting as well, because I think it's of great importance. We also can think beyond antenatal care, so things like in housing services, in mental health services, in drug and alcohol services. Where could we be testing? Where could we be finding people who are infected with syphilis and testing them as needed? On the right-hand side there is the report from the Congenital Syphilis Roundtable, which was the second iteration of which was held at the beginning of this year. And one of the steps from the federal government point of view has been to declare infectious syphilis as a CDIN, so a communicable disease incident of national significance. So what this means is that we have the opportunity on a national level to address this problem. And I think that's why it's really important to think about now, how can we use that sort of momentum on a national level to address the grassroots problem. This is my project, which is looking at the experiences of people diagnosed with syphilis in pregnancy. And if I've been interviewing women who are diagnosed and treated for syphilis in pregnancy, and so far themes have been really difficult to access treatment, lots of logistical challenges and gaps in coordination of care, incorrect treatment and problems with repeat treatment, people having to come in to get treated again and again. And this means that people really lose faith in the health system, and unclear information. So written information is often not fit for purpose, too long, that sort of thing. My PhD project rolled out repeat screening for syphilis in later pregnancy at 3 sites across Victoria. But as part of it, we didn't just say, please test your patients. We also included a guideline changes, automatic pathology ordering, prompts within our electronic medical record, and lots of training and education. So this talk is really an extension of that, I would say, and really might be something that you might need to implement in your local service. Let's just talk briefly about partner follow-up, and I'm aware that I'm running out of time. So partner tracing definitely prevents reinfection, and it obviously needs a really strong connection between our antenatal care providers and primary care. We probably don't have the possibility to treat and test and treat all sexual partners in our antenatal care setting. But I don't think it's good enough to just say, "I'll go and see your GP." We probably need to do that much more actively. Where can they go that's going to be free of charge or accessible for them? Where is going to be geographically and culturally accessible? We need to think about these things for the individual sitting in front of us. Paediatric follow-up is obviously incredibly important. And when we look in Victoria, this has been a little bit inconsistent. And that's because of other issues, nothing to do with the service not being available, but being able to access the service is sometimes the problem. And we need to have really clear communication between our antenatal care team, our paediatric team, and then also with our public health units to allow this to occur. I just wanted to talk about some other ideas. some of my colleagues at Melbourne Sexual Health Centre, Beck Wigan and Marcus, have just published on multiplex PCR testing for treponema pallidum and herpes simplex. So this was a really interesting study where any test that was sent for herpes in the primary care setting through one of the private pathology labs in Victoria was then automatically added on syphilis testing, even if it wasn't requested by the clinician. And I guess I've got these pictures here to say to you, what do you think these are? Do you think they could be syphilis? Do you think they could be herpes? Do you think they could be something else? And I'm here to tell you that there's plenty of very, very experienced clinicians who cannot tell the difference. So what the trial by Beck and Marcus showed was that multiplex testing, where we automatically test for syphilis and herpes among patients for whom HSV PCR testing alone was ordered, really did improve detection of primary syphilis in primary care. So this is an easy win, I would say, that could be rolled out in Victoria, where we could test every test that's sent for herpes could have an automatic syphilis test added on, and that could make sure that we don't miss any cases. Another really important area is point of care testing. So to increase syphilis testing coverage among pregnant people, the WHO definitely recommends the implementation of dual HIV and syphilis point of care testing as needed as the first screening test in antenatal care. And the Burnett's been doing some really interesting work. They've delivered this new diagnostic point of care test for syphilis, which allows to determine whether this is a current infection or a previously treated infection. So this is going to be a key priority for using point of care testing, especially in the antenatal care setting, for management of syphilis infections, because there is some concern, obviously, about false or past treated infections and over treatment. But I would say watch this space from the Burnett. So I just wanted you to reflect again. What do you think the biggest barrier is to preventing congenital syphilis? I think you can access the poll again. You can look at what everyone else has said in the answers. But you could also think in your own clinical area what those barriers might be, and think about maybe how you could address them locally. And if you'd like any of the information that I provided, please don't hesitate to email me or contact me. I've talked a bit about the importance of strong surveillance, and I would definitely point to the UK's ISOS screening program, where they present really fantastic data about the syphilis care cascade. This is being worked on also by the Kirby Institute, and I think probably the new CDC will have a role to play in making sure that we have really granular data across Australia to look at where our problems are and to be able to think about how can we strengthen our public health response. We should definitely be implementing universal repeat screening in the Australian setting, and the Australian Pregnancy Care Guidelines support that and often might give you a foot in the door with your local organisation to chat about this issue. We obviously need to invest in sexual health infrastructure. If we have programs, they need to be funded on a longer term basis. We also need to think about systems. So it's probably not enough to just change a guideline. We also need to have prompts within our medical records, within medical director and other primary care software to make sure that the reminder is there. And I think this is going to be big as AI comes into our practice, so that we ensure that syphilis is front of mind given the changing epidemiology. Congenital syphilis is preventable. We do have this Portuguese product available, and we have benzathine penicillin in the doctor's bag. So if we can just get it into the right patients, then this should be something that we can address in Australia. But we need to consistently screen and treat affected populations. And obviously, ongoing surveillance and research is going to be really, really important. We also need to think about partnerships. So I'm here today talking to you as a sexual health physician and also as an ONG. RANZCOG has released a statement about syphilis for maternity care providers, but really this is about everyone in the room being on board. And I'm really open to any ideas that you might have how we could address this in your local setting. There's heaps of amazing tools out there. So through ASHM, who's now providing the national training about syphilis, there's a Train the Trainer course, which is approved for CPD hours through RACGP. There's also some great online resources about decision making in syphilis. So if you see a case, don't feel like you'll be left alone, where everyone's very interested, and certainly even the Victorian Department of Health has contacts who can give you some information about testing, treatment and follow-up. I'd also flag the CDINs, which has been declared, which I talked about earlier, which means that this is a really important incident of national significance. And again, the really fantastic ASHM resources. And I'll be waiting to see the action of the CDC in this important area. I'd also like to thank my colleagues at Melbourne Sexual Health Centre and the Women's and Monash University who've helped with this project. And there's my email address there, and I'm really open to any questions that you might have. That was a bit of a whistle-stop tour of congenital syphilis, but I'd love your comments because I really think they help shape future action in this area.
Thank you very much, Dr. Bond, for that fantastic and very comprehensive presentation on the prevention of congenital syphilis. We really appreciate your time today. Now, I have been monitoring the chat, and it doesn't look like there's any questions at the moment, but I just wanted to quickly open the floor to ask if anybody had any questions. From Emma, have all the hospitals adopted the additional syphilis testing in pregnancy?
No, so I would say that implementation has been patchy, and this has been some of my syphilis or my PhD work is about really trying to integrate repeat screening in later pregnancy. And the sites that were involved in my project are Monash, the Women's, and Sunshine Hospital or Joan Kerner, who've definitely implemented syphilis screening in later pregnancy around that 28-week mark. The repeat screening at 36 weeks or birth has not been widely implemented thus far, and that's something that we're trying to address. I think one of the key messages is if we test more frequently, then we normalise testing and we make sure that it's at the forefront of mind for clinicians. And my concern is if uptake is not great within each individual hospital, then there is absolutely a chance that we miss a case of congenital syphilis. So in our study, we found 3 cases of syphilis diagnosed, 1 at each site at that 28-week test. So these were people that were negative for syphilis in the first trimester and were screened again. And that's data that we'll be publishing in the coming months. In terms of that repeat test in the 3rd trimester, there's obviously some concerns about the cost effectiveness of that, but there is no reason why a sexually active person could not be reinfected with syphilis later in pregnancy. And obviously that puts the neonate at great risk. So that's why the guidelines have been changed. There's good data from other jurisdictions where there's very high rates of syphilis that shows that repeat screening can make a difference. So this is something that we're trying to implement across all the services.
Thank you for that. And is the opt-out testing in the UK for emergency departments only?
Yeah, and there's been some amazing projects which are about anyone coming in through the door in different emergency departments in the UK who are having blood tests will automatically have an HIV and syphilis test added. And they've shown that the prevalence of syphilis in the ED population is higher than in the general community. In other words, we're targeting a high-risk group. The follow-up of that occurs through the GUM clinics, and there's often collaborative plans within each hospital service. And I think that's something we could think about doing here. I think everyone worries about the workload in emergency departments, which is absolutely fair enough. And there's some things to be worked through from that point of view. But a positive result and a detected infection means a reduction in onward transmission. So that would be a priority population within our sexual health services. So I'd hope that there'd be quite a lot of buy-in from the sexual health side of things to support that sort of project. And it's been interesting. from some of the UK data showing the effectiveness of follow-up. These patients have sometimes never been tested before. So we're not just capturing those that are regularly getting screened through emergency department opt-out screening, we're capturing those that may have never been tested.
Great. And is there any legislation being looked at for testing partners at the antenatal care setting?
So I think we have to be careful from a legislative point of view because actually we've got to imagine the complexity of some of these relationships. And we know that in situations where there may be, unsafe relationships or multiple sexual partners or whatever, we need to just be careful that if we're notifying sexual partners that that's a safe thing for that individual. And we can support that by using our public health units to provide confidential notification and offering some of those services. But I don't think that legislating partner notification would be safe for some of the cohort that I see. And we just need to be a little bit careful. And just understand the complexities behind some of these infections. So there's a lot of coercive control and other things that we do see that we don't want to undo some of those safety things that we've rolled out within our clinical setting.
And are there any data collections being done on trans and gender diverse people in pregnancy that you're aware of?
Yeah, and I think that's an important point. I guess I've used the terminology pregnant woman over and over and over, which is really not correct. I should be using different terminology, and I apologise for that. I think it's in Victoria there isn't much data on that population as far as I am aware in terms of syphilis notifications, but that'd be something that I think is of great interest and should be a point of research in the future.
When changes have been made to guidelines on testing/screening procedures, have you seen there to be issues in disseminating that information/change down to the service level to implement?
Oh, 100%. And that's why I guess I'm here to say we can change a guideline till the end of time, but it gets stuck behind 55 other guidelines and competing priorities. So unless we go out there and use some implementation science principles, we need to have a local champion. We need to think about other ways of educating. We also probably need to make obvious reminders. So in our obstetric reporting software, which is BOSS, there's automated reminders. You can't move on to the next field until you've filled out the syphilis testing in the third trimester box. And that's quite helpful in the services that are using BOSS as like a little clinical reminder for clinicians, because there's 100 other things that they're also thinking about. And so we need to make these things really protocolized and part of our EMR in all the different settings. And I guess that's really complex thing to do because every service is using something different. Every primary care service is using something different. But I think it's not insurmountable. And in my PhD project, we did look at every service and make a prompt in each service so that clinicians didn't just have to remember this as an issue, it was just part of routine care.
That's great. Thank you so much, Dr. Bond. That will probably bring our presentation to a close. It doesn't look like there's any more questions that I have missed in the chat. But again, we just want to thank you for coming and speaking and for your presentation, and also for everyone coming and attending. We hope you have enjoyed, and that will be it from us today. So thank you so much.
Thanks, everyone.